Hello everyone, in this video we're going to talk about airway assessment, an essential step we must always perform before intubating any patient. Before we manage the airway, we need to understand what it is. The airway is the pathway that carries air from the nose and mouth down to the lungs, including the nasal passages, oral cavity, pharynx, larynx, and trachea. If it isn't clear, gas exchange can't occur properly, and serious problems can develop quickly. Any issue along this path, whether structural or functional, can affect breathing and oxygen delivery, which is why assessing the airway first is so important. But sometimes, because of certain patient factors or clinical situations, the airway can give us trouble, meaning we might not be able to ventilate or intubate the patient. When that happens, we call it a difficult airway. Clinically difficult airway is defined as a situation where a trained anesthesiologist cannot easily ventilate with a mask, cannot intubate the trachea, or both. Different guidelines describe it a little differently though. The American Society of Anesthesiologists defines a difficult airway as existing when a conventionally trained anesthesiologist experiences difficulty with face mask ventilation of the upper airway, difficulty with tracheal intubation or both. The Canadian guidelines are broader. They define it as a situation where an experienced provider anticipates or encounters difficulty with any or all of face mask ventilation, direct or indirect laryngoscopy, tracheal intubation, supraglottic airway use or surgical airway. So difficult airway is a broader term used to describe the wider sets of airway issues that we might encounter. Among them, what concerns us the most is the difficult mask ventilation and difficult intubation because they are a primary weapon when dealing with a patient's airway. Let's define them too. Difficult mask ventilation is defined as the inability to maintain SpO2 or oxygen saturation above 90% using 100% oxygen with a face mask. And, difficult intubation is defined as requiring more than 3 attempts or taking more than 10 minutes to successfully intubate using conventional laryngoscopy. The incidence of difficult bag mask ventilation is reported to be between 1.4% and 15%, while difficult intubation ranges from 5% to 8% when using a standard laryngoscope. So, what exactly are we aiming to achieve with airway assessment? Well, the main goal is to help us spot any risk factors that could make ventilation or intubation difficult. If we think the airway could be tricky, we can get backup ready like a video laryngoscope, a fiberoptic scope, an LMA, or even surgical airway tools before things get out of hand. For this we follow a difficult airway algorithm which we will see in a separate video. You can pause the video and check this algorithm, which is self-explanatory. Finally, let's move on to the main topic of this video, assessment of the airway. There isn't a single test that can perfectly predict difficulty, so we always combine history, physical examination, and sometimes investigation. In history, we often find the first and most important clues about a potentially difficult airway. We go through the patient's notes and anesthesia records to check if there has ever been any difficulty with intubation or mask ventilation in the past. We also ask about neck surgeries, burns, or trauma that might have altered the airway anatomy. Concurrent conditions like obesity and obstructive sleep apnea, congenital syndromes in pediatric cases, diabetes arthropathy, head and neck radiation therapy and rheumatoid arthritis and other connective tissue disorders. Finally, we always check the timing of the last meal because a full stomach increases the risk during airway management. In general examination, we basically examine the airway from the mouth to the trachea. An easy way to remember this is by using the mnemonic 5D. The first D is dentition. Here, we look at the patient's teeth and jaw structure. Prominent upper incisors, loose teeth, edentulous gums, or a receding chin can all make bag and mask and laryngoscopy more difficult. The second D is distortion. This refers to anything that alters the normal anatomy, such as swelling, infection, tumors or trauma. The third D is disproportion, which describes an imbalance in airway structures that can make ventilation and intubation harder. A large tongue relative to the mouth can block the laryngeal view, a small mouth opening limits laryngoscope access, a short neck reduces space to align airway axes, and a thick neck adds bulk that hinders visualization. The fourth D is dysmotility, which refers to restricted movement of the jaw or cervical spine that can complicate airway management. Limited jaw opening, such as intrismus, temporomandibular joint disorders, or post-radiation fibrosis reduces the space for inserting and maneuvering the laryngoscope. Reduced neck mobility, seen in cervical spine injury, arthritis or ankylosing spondylitis prevents optimal head extension and alignment of the oral, pharyngeal, and laryngeal axes, making glottic visualization more difficult. And finally, the fifth D covers other difficult features that may not change airway anatomy but still complicate management. Massive obesity adds soft tissue bulk, impairs mask seal, and speeds desaturation. Pregnancy causes airway edema, reduced lung volumes, and higher oxygen demand, shortening safe apnea time. Facial hair can break mask seal, and tubes or devices like nasogastric tubes or cervical collars can obstruct access or positioning. We should also note that mask ventilation precedes laryngoscopy, which in turn is followed by intubation, so the assessment should follow a systematic sequence that mirrors these steps. The first step is to consider predictors of difficult mask ventilation, for which mnemonics like moans and bones are widely used. MOAN stands for mask seal problems, obesity, age greater than 55 years, no teeth, and snoring or sleep apnea. BONE stands for beard, obesity, no teeth, elderly, and snoring or sleep apnea. The presence of any one of these features should raise suspicion for potential difficulty in mask ventilation. When it comes to predicting difficult laryngoscopy and intubation, there are a lot of individual bedside tests and grouped scoring systems, but in clinical practice, one of the most practical and widely used is the Lemon assessment. Lemon is a simple mnemonic that helps us quickly remember and perform the essential steps of airway evaluation. We will look into them in detail. Look externally means performing a rapid visual survey of the patient's face and neck for any obvious findings that might complicate airway management. We have discussed them in the 5 Ds of airway examination. Evaluate 332 refers to the simple bedside measurements used to estimate the available space for laryngoscopy and intubation. This rule involves 3 sequential measurements performed with the head in a neutral position. The first step is measuring mouth opening. The patient is asked to open their mouth as wide as possible, and the assessor places their own fingers or uses the patient's fingers vertically between the upper and lower incisors to estimate the gap. A normal mouth opening should allow at least 3 finger breadths. This indicates that there is adequate space to insert and manipulate the laryngoscope blade during intubation. The second step is measuring the mandibular space, which is the distance from the tip of the chin to the hyoid bone. This is again estimated using finger breadths, with 3 finger breadths considered normal. Adequate mandibular space allows the tongue to be displaced anteriorly during laryngoscopy without compressing airway structures. The third step is measuring the distance from the hyoid bone to the thyroid notch, which reflects the vertical position of the larynx. A normal measurement is at least 2 finger breadths. A shorter distance suggests a more anterior larynx, which can make glottic visualization more challenging. Along with the Lemon criteria, the assessment can also include the thyromental distance and the upper lip bite test. The thyromental distance is the straight line measurement from the thyroid notch to the tip of the chin with the neck fully extended. It serves as an indicator of the mandibular space available to accommodate the tongue during laryngoscopy. A measurement of less than 6.5 centimeters or approximately 3 finger breadths suggests limited space. The upper lip bite test evaluates mandibular mobility and dental architecture by assessing the patient's ability to bite the upper lip with the lower incisors. Restricted movement or inability to reach the vermilion border of the upper lip correlates with reduced oral access and more challenging glottic visualization. M in lemon stands for Mallampati, referring to the modified Mallampati classification which assessed the visibility of certain structures during maximal mouth opening with the tongue protruded. The patient is seated upright, instructed to open the mouth fully and stick out the tongue without making any sound. The examiner notes the structures visible. In Class 1, the soft palate, fauces, uvula and pillars are visible. In Class 2, the soft palate, fauces, and uvula are visible, but the pillars are not. In Class 3, only the soft palate and base of the uvula are visible. In Class 4, only the hard palate is seen. Progressively higher classes correlate with reduced oropharyngeal space and a greater likelihood of a difficult laryngoscope view. The O in lemon stands for obstruction, which refers to anything that narrows, blocks or distorts the airway. This includes structural issues like tumors, swelling, enlarged tonsils or congenital abnormalities. It also covers traumatic causes such as facial fractures, hematomas, bleeding, or foreign bodies in the airway. Lastly, inflammatory or infectious conditions like epiglottitis, abscesses, or severe allergic reactions can cause airway swelling. Warning signs like stridor, muffled speech or difficulty swallowing should raise concern for obstruction. Finally, neck mobility describes how well a patient can move their neck, especially bending the head forward and extending it backward. These movements are important because they help line up the oral, pharyngeal and laryngeal axes, which is essential for successful direct laryngoscopy. The sniffing position, achieved by flexing the neck forward and extending the head at the atlanto-occipital joint, helps align these axes for easier intubation. At the bedside, you can check neck mobility by asking the patient to bend the head forward so the chin touches the chest to assess flexion, and then to look up as far as possible to assess extension. Measuring the sternomental distance, which is the distance from the tip of the chin to the top of the sternum with the neck fully extended, is another useful test. A measurement of less than 12.5 cm suggests limited mobility. Limited neck extension can result from cervical spine disease, previous spinal fusion, halo fixation, or trauma. We also use combined scoring systems that incorporate multiple individual parameters to predict airway difficulty. One such system is the Wilson score given here. The last part of airway assessment is investigation, which is used when clinical examination suggests potential difficulty or anatomical abnormalities. Neck X-rays can show limited movement or unusual anatomy, while CT and MRI provide detailed views in cases of tumors, trauma, or congenital anomalies. Ultrasound helps assess tongue size, preepiglottic space, and locate the cricothyroid membrane, and flexible endoscopy allows direct visualization of obstructions or lesions. These investigations complement the bedside assessment and help plan airway management in difficult cases. Once the airway assessment is done, we proceed with laryngoscopy, where we encounter different views of glottic structures. These views are described by Cormack-Lehane laryngoscopic view. Grade 1 means the full glottis is visible, indicating easy intubation. Grade 2 shows only a partial view of the glottis, which may require some manipulation like pressure on the anterior neck by assistant. Grade 3 reveals only the epiglottis, making intubation more challenging and often needing adjuncts like a bougie or video laryngoscope. Grade 4 shows neither the glottis nor the epiglottis, representing a potentially very difficult or impossible intubation without advanced airway techniques. This grading system helps anesthesiologists anticipate difficulties, plan alternative strategies, and document airway findings for future reference. To end the video, airway assessment also involves anticipating potential difficulties with backup techniques, like using supraglottic airway devices, in case standard intubation fails. The RODS mnemonic helps guide this evaluation. R stands for restricted mouth opening, which can make device insertion challenging. O is for obstruction such as tumors, swelling, or foreign bodies that may block the airway. D refers to distorted airway anatomy, including congenital anomalies, trauma, or previous surgery that alters normal structures. S stands for stiff lungs or cervical spine, which may limit neck movement or lung compliance, complicating ventilation. Airway management is a critical skill in anesthesia and emergency medicine, as failure to secure the airway can rapidly cause hypoxia, brain injury, or death. That's why anticipating difficulties and preparing in advance is so important, as we have discussed earlier in the assessment part. In this session, we'll focus on basic airway management, including patient positioning, simple airway opening maneuvers, airway adjuncts, and bag valve mask ventilation. The airway is divided into the upper and lower portions. The upper airway includes the nasal cavity, oral cavity, pharynx, and larynx. The lower airway begins at the trachea and extends to the bronchi and alveoli. Key landmarks include the tongue, epiglottis, vocal cords, and cricoid cartilage. The tongue is the most common cause of airway obstruction in unconscious patients. In addition to knowing the airway structures, it is important to understand how they function during breathing and airway manipulation. The pharyngeal muscles help maintain airway patency when a patient is awake, but they relax under anesthesia or sedation, which can lead to airway collapse. The epiglottis closes during swallowing to prevent aspiration, and the tongue is normally held in position by its intrinsic and extrinsic muscles. These protective mechanisms can be compromised during airway interventions or when the patient is unconscious. When this happens, simple but effective techniques are needed to reopen the airway and keep it clear. These are known as basic airway maneuvers. The most commonly used maneuver to open the airway is the head tilt, chin lift. To perform this, the rescuer stands at the patient's head and places one hand firmly on the forehead to gently tilt the head backward. The fingers of the other hand are placed under the bony part of the mandible to lift the chin upward. This combined motion of tilting the head and lifting the chin moves the tongue away from the back of the throat, helping to clear the airway. However, this technique should not be performed if a cervical spine injury is suspected. In such cases, the jaw thrust maneuver is the preferred method. To perform this maneuver, the rescuer places their fingers behind the angles of the mandible on both sides of the face and then pushes the jaw forward. At the same time, the thumbs can be used to gently lift the chin if needed. This forward movement of the mandible lifts the tongue and epiglottis away from the back of the throat, opening the airway without moving the cervical spine. Although the head tilt, chin lift, and the jaw thrust are two separate airway maneuvers, they can also be performed together in combination. This is known as the triple airway maneuver. It involves tilting the head, performing a jaw thrust, and opening the mouth. The triple airway maneuver is considered the most effective manual method of opening the airway during resuscitation, before the placement of airway adjuncts or the use of bag valve mask ventilation, provided there is no suspicion of cervical spine injury. Despite using optimal airway opening maneuvers, sometimes the airway cannot be adequately opened because the tongue and soft tissues continue to obstruct the pharynx. In such cases, an artificial airway adjunct is required. Two most commonly used basic adjuncts are the oropharyngeal airway and the nasopharyngeal airway. The oropharyngeal airway is a curved plastic device that sits over the tongue and extends into the pharynx. Its main function is to prevent the tongue from falling back and blocking the airway. To insert the oropharyngeal airway, first hold it upside down with the tip pointing toward the roof of the mouth. Gently advance the tip until it reaches the soft palate. This positioning prevents the tongue from falling back and blocking the airway. Then rotate the airway 180 degrees so it follows the natural curve of the tongue. Finally, push the airway in until the flange or the flat part at the opening rests snugly against the patient's lips. Choosing the correct size is important, and the appropriate airway is one that extends from the corner of the mouth to the angle of the mandible. It should only be used in unconscious patients without a gag reflex, because insertion in a patient who is awake or semi-conscious can trigger gagging, vomiting, or laryngospasm. Unlike the oropharyngeal airway, a nasopharyngeal airway is better tolerated in patients who are semi-conscious or have an intact gag reflex. It is especially useful when mouth opening is limited, or facial trauma prevents the use of an oropharyngeal airway. To insert, gently advance the airway into the chosen nostril with the bevel facing the septum, following the natural curve of the nasal passage. A gentle twisting motion may help if resistance is encountered. If insertion is difficult, do not force the tube, instead, rotate slightly or try the other nostril. The airway is correctly positioned when the flange rests against the nostril and the tip sits in the nasopharynx above the epiglottis without obstructing airflow. The correct size is chosen by measuring from the tip of the nose to the tragus of the ear. However, nasopharyngeal airways should be avoided in cases of suspected basilar skull fracture because of the risk of intracranial placement. We will now move on to bag mask ventilation, which is the most important step to ensure that the patient is both ventilated and oxygenated. This technique is the backbone of basic airway management, and when done well, can stabilize most patients while more definitive measures are prepared. Effective bag mask ventilation depends on optimal positioning to keep the airway open, and on maintaining a reliable mask seal. Let's begin with positioning. The most effective position in most adults is the sniffing position, provided there is no concern for cervical spine injury. This involves flexing the neck on the torso and extending the head at the atlanto-occipital joint, usually with the help of a pillow or folded towel placed under the occiput. When done correctly, the external auditory meatus should align with the sternal notch. The sniffing position helps align the oral, pharyngeal and laryngeal axes, making the airway more open. This is why it not only improves the effectiveness of bag mask ventilation but is also considered the standard position for direct laryngoscopy during intubation. However, some patient groups need modifications. In obese patients, a ramped position is preferred, where the head and upper torso are elevated together so that the ear canal and sternal notch are brought into the same plane. You can appreciate this positioning by comparing it to the picture on the left. In infants, the large occiput naturally flexes the neck, so a pillow is usually not required. In fact, placing a small rolled towel under the shoulders is often more helpful, as it prevents excessive flexion caused by the prominent back of the head. The infant's head should not be fully extended like an adult, instead, it should be tilted back only slightly, as if gently sniffing the air. For older children, the prominence of the occiput decreases, so a headrest or slight ramping under the head may be sufficient to achieve the sniffing position. Unlike neonates, head extension is often required for positioning. Across all age groups, the universal principle remains the same. The goal is to align the external auditory meatus with the suprasternal notch and to bring the glabella, chin plane close to horizontal. So, the use of a shoulder roll, headrest or ramping all depends on achieving the airway alignment we have discussed, irrespective of the patient's age. As you can see in the pictures given here, the infant is positioned with head rest along with the shoulder roll to achieve the sniffing position. If a cervical spine injury is suspected, the sniffing position should not be attempted. Instead, the head must be kept in a neutral position, and a continuous jaw thrust should be applied to lift the tongue away from the posterior pharynx. If airflow remains obstructed despite this, an oropharyngeal or nasopharyngeal airway can be inserted promptly to keep the passage clear before and during mask ventilation. The next important step in bag and mask ventilation is achieving the tight seal. For this, the first step is to ensure that we select the correct mask size. The mask should extend from the bridge of the nose to the cleft of the chin, covering both the nose and mouth without pressing on the eyes. A mask that is too large may leak around the chin or compress the eyes, while one that is too small may not fully enclose the airway. Once the appropriate mask is chosen, the key is to create a snug fit between the mask rim and the contours of the face. The most commonly taught method for holding the mask is the C-E technique, which can be performed with one hand or using both the hands. In one-handed approach, the thumb and index finger form a C shape around the top and sides of the mask, pressing it gently onto the face, while the remaining three fingers form an E under the mandible to provide the jaw thrust. However, in situations where leaks persist or when one-hand ventilation is insufficient, the two-hand mask holding technique becomes necessary. In this method, both hands form the CE grip on either side of the mask, while an assistant squeezes the bag. This approach provides a stronger and more reliable seal, especially in obese, edentulous, or bearded patients where achieving an airtight fit can otherwise be difficult. In adults, certain situations make achieving a seal more difficult. In edentulous patients, the absence of teeth leads to collapsed lips and cheeks, producing leaks. Leaving dentures in place when possible or packing the cheeks with gauze restores contour and improves the seal. In obese patients or those with redundant soft tissues, extra jaw thrust and the two-hand technique are usually required. Beards may also interfere with the seal, which can be improved by applying water-soluble gel to the mask rim or shaving the area when feasible. In our previous video, we discussed basic airway management, which included airway opening maneuvers like chin lift and jaw thrust, the use of oropharyngeal and nasopharyngeal airways, and bag mask ventilation. In this video, we will move into advanced airway management, which includes the use of devices such as the laryngeal mask airway, endotracheal intubation, and surgical techniques for securing the airway when basic methods are not sufficient. The first device in advanced airway management is the laryngeal mask airway or LMA. The LMA is a supraglottic device, which means it sits above the vocal cords rather than passing through them. Although there are different types of laryngeal mask airways, they all share a similar design. Each consists of a tube connected to a mask with an inflatable cuff at the end. When inserted, the mask sits in the hypopharynx and the cuff is inflated, creating a seal around the laryngeal inlet. This allows ventilation to be delivered effectively without the need for endotracheal intubation. Even in cases of difficult airway or failed intubation, the laryngeal mask airway serves as a valuable backup when conventional bag and mask ventilation is not sufficient to maintain the airway. Some advanced types of LMAs are specifically designed to allow intubation through them, and these are known as intubating LMAs. Despite the availability of different types of laryngeal mask airways, the basic insertion technique remains relatively the same. Preparation begins with selecting the correct size LMA according to the patient's weight and manufacturer's recommendations. The table here shows the size guide for LMA Classic and the ProSeal. As for the insertion, the patient is placed supine in the sniffing position, which is often achieved using the triple airway maneuver. This maneuver helps align the oral, pharyngeal, and laryngeal axes, making insertion smoother and more effective. We have discussed positioning in our previous video. At the same time, we must ensure that patient doesn't awaken during insertion. If necessary, sedation may be used to prevent gagging or movement. Prior to insertion, the cuff should be inflated and deflated to check for leaks and to ensure that it functions properly. Then, with the cuff fully deflated, a small amount of sterile, water-soluble lubricant is applied to the posterior surface of the distal mask and cuff. The deflated LMA is held between the thumb and index finger, in the same way one would hold a pen or pencil, with the aperture facing the laryngeal inlet. The device is gently inserted into the mouth and guided along the hard palate and then the soft palate. Using the index finger at the junction where the tube meets the mask, gentle pressure is applied to advance the device cephalad so that the posterior surface of the mask follows the curve of the palate. The mask should advance smoothly until it meets definitive resistance at the entrance of the esophagus, which indicates that the tip is correctly seated in the hypopharynx. At this point, the bite block of the tube should rest at the level of the patient's incisors. Once the mask is in position, the hand is released from the tube before inflating the cuff. The cuff is then inflated with air, typically beginning with recommended volume. As the mask seats over the glottic opening, the tube will generally protrude 1 to 2 centimeters out of the mouth. The airway is then connected to a bag valve apparatus. Adequacy of ventilation is assessed by observing chest rise, auscultating breath sounds bilaterally, and confirming with end-tidal carbon dioxide monitoring. Once proper placement is confirmed, the LMA is secured with tape or another fixation method to prevent displacement during use. However, before attempting LMA insertion, caution is needed. The RODS mnemonic helps guide this evaluation. R stands for restricted mouth opening, which can make insertion difficult. O is for obstruction, such as tumors, swelling, or foreign bodies that block the airway. D refers to distorted airway anatomy, whether from congenital anomalies, trauma, or previous surgery. S stands for stiff lungs or cervical spine, which can limit neck movement or lung compliance and complicate ventilation. The patient must also be unconscious or adequately sedated to suppress the gag reflex before LMA insertion. There is also an increased risk of regurgitation in patients with prolonged prior bag mask ventilation. In those who are obese, pregnancy or who have upper gastrointestinal problems such as reflux, hiatal hernia, or a history of GI surgery or bleeding. Patients who have not fasted are also at risk. In emergencies, however, an LMA may still be used despite these relative contraindications. Finally, in patients who require high-pressure ventilation or PEEP, the standard LMA may not provide an adequate seal. In such cases, an endotracheal tube is preferred to deliver safe ventilation when there is significant airflow resistance in the lower airways or lungs. That is why endotracheal intubation is considered the gold standard of advanced airway management. It involves passing a tube through the vocal cords into the trachea, securing a definitive airway with a good seal. Compared with supraglottic devices like the laryngeal mask airway, endotracheal intubation offers superior protection against aspiration, better control of positive pressure ventilation and tidal volume delivery, and is more reliable for prolonged ventilation. There are several major indications for endotracheal intubation. It is performed whenever a patient cannot maintain or protect their own airway, such as those with reduced consciousness after trauma, head injury, or overdose. It is indicated when airway protection from aspiration is essential. It is required in patients with inadequate oxygenation or ventilation despite other measures, for example in severe respiratory failure. It is also performed in the operating room for patients undergoing general anesthesia. In intensive care, endotracheal intubation may be performed prophylactically in patients with burns, facial trauma, or progressive airway swelling where early intubation prevents sudden airway obstruction. A structured airway assessment before attempting intubation reduces the risk of unexpected difficulty. We have covered airway assessment in detail in a separate video. One commonly used tool is the lemon mnemonic. L stands for looking externally at the patient for predictors of difficulty such as obesity, facial trauma, large incisors, or a beard. E refers to evaluating the 3-3-2 rule, which checks that there are at least 3 fingerbreadths of mouth opening, 3 between the mentum and hyoid, and 2 between the hyoid and thyroid notch. M refers to the Malampati classification, which is assessed with the mouth open and the tongue protruded, grading how much of the oropharynx is visible. O stands for obstruction from swelling, infection, bleeding, or tumors. N stands for neck mobility, as reduced extension or flexion can make laryngoscopy more difficult. These elements help predict a difficult airway and allow the clinician to prepare alternative strategies such as a video laryngoscope, a bougie, a supraglottic device, or in extreme situations, a surgical airway. Preparation is essential for a successful intubation. Again, we have a detailed video about it on Rapid Sequence Intubation video. The main point is that we should think of patients, equipment, drugs, backup plans and team roles. For this, mnemonic like stop made can be used to ensure nothing is missed during the preparatory phase. The S stands for suction, which means having a functioning suction device with appropriate catheters ready to clear blood or secretions. The T stands for tools, which include the endotracheal tube of the correct size with smaller and larger alternatives, a working laryngoscope or video laryngoscope, a stylet or bougie, and a bag valve mask. The O stands for oxygen, which means ensuring effective preoxygenation of the patient and checking that a reliable oxygen source with delivery systems is connected and working. The P stands for positioning, which involves placing the patient in the optimal position for laryngoscopy, such as the sniffing position or a ramped position in obese patients. The M stands for monitoring, which means attaching the patient to pulse oximetry, ECG, blood pressure monitoring, and preparing capnography for confirmation. The A stands for assistant, which highlights the importance of having a trained helper who understands their role, whether it is passing equipment, applying cricoid pressure if needed. The I stands for intravenous access, which requires at least one secure and functioning IV line. Finally, the D stands for drugs, which means drawing up and labeling the induction agent and neuromuscular blocker, as well as preparing rescue medications such as vasopressors and analgesics. The ideal position is the sniffing position, with the head extended and neck flexed to align the oral, pharyngeal, and laryngeal axes. In obese we will have to use the ramped-up position to achieve the sniffing position. If cervical spine injury is suspected, manual inline stabilization is performed instead. After the induction and paralysis, the laryngoscope blade is inserted into the right side of the mouth and advanced, sweeping the tongue to the left. For a Macintosh blade, the tip is positioned in the vallecula to indirectly lift the epiglottis, whereas for a Miller blade the epiglottis is directly lifted. The vocal cords are then identified, and an appropriately sized endotracheal tube is advanced through them into the trachea. In adults, the depth of insertion depends on the patient's height, but as a general guide it is usually about 23 cm at the incisors in males and about 21 cm in females. In children, formulas are available to guide both the selection of tube size and the appropriate depth of insertion. Once the tube is in place, the cuff is inflated and ventilation is commenced. Correct placement of the endotracheal tube is verified using multiple methods. These include direct visualization of the tube passing between the vocal cords, observation of bilateral chest rise and fall with ventilation, 5-point auscultation, and the presence of a consistent end-tidal CO2 waveform. Additional indicators are sustained improvement in oxygen saturation, visible condensation within the tube during exhalation, and radiological confirmation with a chest X-ray. In patients breathing spontaneously on a Bain circuit or a circle system in the open position, rise and fall of the reservoir bag may also be seen. Among all these techniques, continuous end-tidal CO2 monitoring remains the gold standard for real-time confirmation in both operative and emergency settings. A surgical airway is a method of gaining direct access to the trachea through an incision in the front of the neck in order to provide oxygenation and ventilation when normal airway techniques fail or is not feasible. The main types of surgical airways are cricothyrotomy and tracheostomy. Cricothyrotomy is a rapid procedure done through the cricothyroid membrane and may be performed by needle, percutaneous, or open surgical techniques. Tracheostomy is a more complex procedure that creates a direct opening into the trachea, performed either surgically or percutaneously. Surgical airways become necessary when conventional techniques such as bag mask ventilation, laryngeal mask airway and endotracheal intubation fail, a situation referred to as cannot intubate, cannot oxygenate. In this scenario, surgical airways are usually achieved through cricothyroidotomy as it offers the quickest and most accessible route into the airway. These are termed emergency surgical airways or emergency front of neck access. Beyond emergencies, surgical airways may be performed electively when prolonged ventilation is required to prevent injury from an endotracheal tube, or when upper airway obstruction from tumors, trauma, or scarring is anticipated. They are also used in major head and neck surgery or in patients with neuromuscular disease needing long-term support. In such cases, tracheostomy is preferred over cricothyrotomy as it offers a safer and more stable long-term airway. However, in this video, we will focus on cricothyrotomy, as we are following a sequential approach to airway management, and cricothyrotomy provides the fastest and most reliable backup should other methods fail. Cricothyrotomy, also called front of neck access, is a surgical procedure in which an opening is made through the cricothyroid membrane to gain direct access to the trachea. The cricothyroid membrane is a thin structure located between the thyroid cartilage above and the cricoid cartilage below. Its superficial position and relatively low vascularity minimize the risk of damage to vital structures and make it the ideal site for emergency front of neck access. To identify the cricothyroid membrane, we begin by palpating the thyroid cartilage, which is often recognized by the prominence of the Adam's apple. From this point, we slide our fingers downward until we encounter a distinct horizontal depression. This soft gap lies between the thyroid cartilage above and the cricoid cartilage below, and this is the cricothyroid membrane. In males, we usually find the cricothyroid membrane easily, while in females, obese patients, or those with distorted anatomy, we may need a more careful and deliberate search. The Difficult Airway Society 2015 recommends using the laryngeal handshake to systematically identify the laryngeal structures. In this method, we begin by grasping the top of the larynx at the greater cornu of the hyoid bone and gently rolling it side to side, appreciating the cartilaginous framework of the larynx. From there, we slide our fingers down over the thyroid cartilage, then continue sliding until the middle finger and thumb are over the cricoid cartilage while the index finger palpates the cricothyroid membrane. Ultrasound can be used to identify the cricothyroid membrane, especially in patients with difficult or obscured anatomy such as obesity, neck swelling, or trauma. A high-frequency linear probe is placed on the anterior neck in a longitudinal orientation. The tracheal rings and cricoid cartilage are described as a string of pearls, with the largest pearl at the cranial end representing the cricoid cartilage, and the thyroid cartilage lying above it. The cricothyroid membrane lies between these cartilages. The primary techniques for cricothyrotomy are surgical, needle, and percutaneous approaches. In the surgical technique, a scalpel is used to create a direct incision into the cricothyroid membrane. The needle method involves passing a large bore catheter over a needle to provide temporary oxygenation. The percutaneous technique employs a guide wire and dilator system, often based on the Seldinger method, to place a tube securely. To make the process easier and more standardized, several commercial kits are available that integrate these steps by including a scalpel, a bougie or introducer, and a cuffed tracheal tube in a single system. The surgical technique, called scalpel, bougie, tube technique is recommended by the Difficult Airway Society for emergency surgical front of neck access because it is quick and uses equipment that is readily available. The procedure begins by placing the patient supine with the neck extended to optimize exposure, and identifying the cricothyroid membrane using the laryngeal handshake technique. If the membrane is palpable, a transverse stab incision is made through it with a scalpel. The blade is then rotated 90 degrees so that the sharp edge faces caudally. Doing so, extends that incision site so that the bougie and the endotracheal tube passes smoothly later. The bougie is inserted with the tip facing caudally toward the lungs. Gentle clicks or tracheal rings can be felt, confirming tracheal placement during the advancement. A lubricated 6 mm cuffed endotracheal tube is then railroaded over the bougie into the trachea. Once the tube is in place, the cuff is inflated and the bougie is removed. The tube is then connected to a bag valve mask or ventilator, and placement is confirmed with capnography, chest rise, and auscultation. If the cricothyroid membrane is impalpable, a vertical 8 to 10 cm skin incision is made from caudad to cephalad. Blunt dissection with both hands is performed to separate tissues and identify the larynx. Once the membrane is located, the technique described for a palpable membrane is then followed. Needle cricothyroidotomy is another method of establishing front of neck access. It creates a temporary airway by inserting a large bore cannula through the cricothyroid membrane into the trachea. This technique is often useful in infants and children because it carries a lower risk of airway damage compared to surgical cricothyrotomy. The equipment required includes a 12 to 14 gauge angiocatheter, a 3 to 10 milliliter syringe filled with saline, high-pressure oxygen tubing for jet ventilation or a bag valve mask device. The procedure begins by placing the patient supine with the neck extended if possible to optimize exposure of the airway. The thyroid cartilage is stabilized with the non-dominant hand, and the cricothyroid membrane is identified by palpation. The angiocatheter is attached to the saline-filled syringe, and the needle is inserted through the inferior margin of the cricothyroid membrane at a 30 to 45 degrees angle directed caudally. Continuous negative pressure is applied to the syringe while advancing the needle, and the appearance of air bubbles confirms entry into the trachea. The catheter is then advanced fully while the needle is withdrawn. Because the catheter used in a needle cricothyroidotomy is very narrow, normal bag valve mask ventilation is often not effective. For this reason, two main methods are used to deliver oxygen through the cannula. The first and most commonly used method is jet ventilation, also called high-pressure oxygen insufflation. In this method, the catheter is connected to a jet ventilator device, which in turn is attached to a high-pressure oxygen source such as wall oxygen or an oxygen cylinder. The oxygen is delivered at high pressure, usually in the range of 15 to 50 psi. Short bursts of oxygen are delivered into the lungs under pressure, with passive expiration occurring through the upper airway. Because the catheter is so small, expiration is slower than inspiration. It is therefore essential to allow a long expiratory time to prevent air trapping, barotrauma, or pneumothorax. In some situations, especially when specialized jet ventilation equipment is not available, the catheter can be connected to a bag valve mask device using an adapter or improvised connector, for example by combining the barrel of a syringe with the universal connector from an endotracheal tube. With this method, oxygen is delivered with each bag squeeze, but because of the narrow lumen, tidal volumes are small and ventilation is limited. Both methods of ventilation in needle cricothyrotomy are temporary measures intended only to maintain oxygenation until a surgical cricothyrotomy or tracheostomy is performed. The next method to gain front of neck access is percutaneous cricothyrotomy using Seldinger's technique, which employs a guide wire and dilator system. It is started by identifying and palpating the cricothyroid membrane in the midline of the neck as discussed in other methods. A needle attached to a saline-filled syringe is then inserted through the membrane at about a 45-degree caudal angle while aspirating continuously. The appearance of air bubbles in the syringe confirms entry into the trachea. Once tracheal placement is confirmed, the catheter is advanced over the needle, and the needle is withdrawn, leaving the catheter in place. A guide wire is then threaded through the catheter into the tracheal lumen, after which the catheter is removed. To facilitate passage of the airway device, a small skin incision is made at the guide wire entry site. A dilator loaded with the airway catheter or tracheal tube is then advanced together over the guide wire into the trachea. The dilator and guide wire are then removed, leaving the airway catheter in situ. After that, the tracheal tube is connected to the bag mask or ventilator. Placement is confirmed by aspiration of air, capnography, chest movement, or auscultation, and finally the catheter is secured to provide a definitive airway. Commercial kits are also available for percutaneous cricothyrotomy using the Seldinger technique, providing all essential components in a single ready-to-use set. Some kits, like QuickTrach, do not use a guide wire or scalpel. Instead, a needle cannula unit is inserted directly through the cricothyroid membrane. In our previous videos, we discussed how to assess the airway and manage it step by step, beginning with simple maneuvers such as head tilt and jaw thrust, and progressing to advanced techniques like cricothyrotomy. In this video, we will focus on the difficulties that may arise during airway management, especially the definition of a difficult airway and the predictors that can help identify it in advance. Generally, difficult airway is defined as a situation where a trained anesthesiologist cannot easily ventilate with a mask, cannot intubate the trachea, or both. We call this scenario can't intubate, can't oxygenate situation. So difficult airway is a broader term used to describe the wider sets of airway issues where we might not be able to ventilate or oxygenate the patient. Different guidelines describe the definition of a difficult airway somewhat differently. The American Society of Anesthesiologists defines it as a situation where a conventionally trained anesthesiologist experiences difficulty with face mask ventilation of the upper airway, difficulty with tracheal intubation, or both. The focus here is on the practitioner, meaning the difficulty is judged by the experience of a conventionally trained provider rather than by an absolute patient characteristic. The definition highlights two core challenges, which are face mask ventilation and tracheal intubation. The Canadian guidelines take a broader view. They define a difficult airway as a situation where an experienced provider either anticipates or encounters difficulty with any or all of face mask ventilation. Laryngoscopy, tracheal intubation, supraglottic airway use, or surgical airway. A difficult airway in this context can be recognized beforehand, which is referred to as an anticipated difficult airway, or it may only become apparent during the procedure, which is referred to as an encountered or unanticipated difficult airway. It also covers various methods of airway support, including face mask ventilation, laryngoscopy, intubation, the use of supraglottic devices such as the laryngeal mask airway, and the potential need for a surgical airway. The Difficult Airway Society itself acknowledges that there is no single, fixed definition of a difficult airway. Instead, they recognize that different definitions exist in the literature and leave it to the clinical judgment of the anesthetist to decide whether an airway qualifies as difficult. Importantly, all three societies also acknowledge that difficult extubation should be considered a part of the broader concept of the difficult airway. There are two main situations in which a difficult airway may occur. These are anticipated and unanticipated airway difficulty. An anticipated difficult airway is recognized before induction through assessment of factors such as Mallampati score, thyromental distance, mouth opening, and neck mobility, allowing the anesthesiologist to prepare with optimized positioning, advanced devices, additional help, or even awake fiberoptic intubation. An unanticipated difficult airway arises unexpectedly during airway management despite normal assessment findings. This is more dangerous because it leaves the team unprepared and increases the risk of hypoxia, making rapid recognition and a structured backup plan essential. Difficult airway can occur at various stages, starting from mask ventilation, supraglottic airway insertion, laryngoscopy, and intubation, to front-of-neck access. Let's begin with how we anticipate and recognize difficult mask ventilation. Mask ventilation is the first-line method to oxygenate the patient. It is primarily used before other airway strategies, such as intubation or supraglottic airway insertion, are planned or attempted. During anticipated or unanticipated difficult intubation, mask ventilation serves as a backup to prevent hypoxia if initial intubation attempts fail. This provides time to reassess the airway, optimize patient positioning, and decide whether to attempt supraglottic airway insertion or other advanced techniques. According to the American Society of Anesthesiologists, it is defined as a situation in which it is not possible for the anesthesiologist to provide adequate ventilation because of one or more of the following problems. This includes inadequate mask seal, excessive gas leak, or excessive resistance to the airflow. Several reviews and Airway Society teaching materials simplify this into a functional, outcome-based definition, stating that difficult mask ventilation occurs when an unassisted anesthesiologist is unable to maintain oxygen saturation above 90% using 100% oxygen, or is unable to prevent or reverse signs of inadequate ventilation during positive pressure mask ventilation. Both the definitions assumes that standard measures have been applied, including optimal head and neck positioning, use of oropharyngeal or nasopharyngeal airways, and the two-handed mask technique. To predict or anticipate difficult mask ventilation during airway assessment, we can use the Mohs or Bones mnemonic, as discussed in the airway assessment video. This helps identify patients at higher risk for ventilation difficulty and guides preparation and planning. Supraglottic airways are another device widely used in anesthesia as means to secure airway. In the context of a difficult airway, supraglottic airways play a critical role as a backup for oxygenation when mask ventilation is inadequate, and can also serve as a conduit for tracheal intubation in cases where direct laryngoscopy or initial intubation attempts fail. Difficult supraglottic airway insertion is generally defined as a situation in which placement of a device such as a laryngeal mask airway requires multiple attempts, is unsuccessful, or fails to provide adequate ventilation or oxygenation despite correct positioning and optimal technique. Some authors refine this further, describing it as failure to insert the device after 3 attempts by an experienced provider, or failure to achieve effective ventilation and oxygenation after successful insertion because of obstruction, leak, or malposition. The Rod's mnemonic helps predict difficult supraglottic device insertion. Restricted mouth opening can make placement challenging, while obstruction from swelling or masses may interfere with device function. Distorted anatomy can make correct positioning difficult, and stiff lungs may cause high airway pressures in patients with chronic pulmonary disease or obesity. A stiff spine, such as with a cervical collar, can further limit movement and complicate insertion. Laryngoscopy precedes intubation, and an easy laryngoscopy is essential for safe and effective intubation. Difficult laryngoscopy is generally defined as the inability to visualize any portion of the vocal cords after multiple attempts at direct laryngoscopy by an experienced provider, despite optimal patient positioning and external laryngeal manipulation. In practice, it typically corresponds to Cormack-Lehane grade 3 or 4, where only the epiglottis or no glottic structures are visible, despite optimal efforts. As with predicting difficult laryngoscopy, many of the anatomical and clinical predictors overlap for difficult mask ventilation, difficult supraglottic airway insertion, and difficult laryngoscopy or intubation. These predictors can be systematically assessed using the Lemon criteria. Again, the airway assessment part was discussed separately. Finally, we move to intubation, which is the definitive method for securing and protecting the airway. When intubation cannot be achieved, alternative techniques must be used to maintain oxygenation and ventilation, marking the beginning of difficult airway management. Difficult intubation is defined as a situation where a trained anesthesiologist requires multiple attempts, alternative techniques, or prolonged time to successfully place an endotracheal tube, despite optimal positioning and standard equipment. It is specifically considered difficult when more than 3 attempts or more than 10 minutes are required to achieve tracheal intubation with conventional direct laryngoscopy. This definition helps guide clinicians to limit the number of attempts and switch early to a backup strategy such as mask ventilation or insertion of a supraglottic device. Careful assessment, such as the Lemon method, can also be used to predict a difficult airway and plan strategies in advance. Surgical airways, also known as phonia, such as cricothyrotomy and tracheostomy, are considered the last resort interventions during airway management when other attempts have failed. Difficult front-of-neck access refers to situations where establishing a surgical airway is challenging due to anatomical, pathological, or technical factors. Clinicians can use the short mnemonic to remember these risk factors, with S for surgery, H for hematoma, O for obesity, R for radiation, and T for tumor. In our previous videos, we discussed the definitions of a difficult airway, which included difficult mask ventilation, difficult supraglottic airway insertion, difficult laryngoscopy, and difficult intubation. In this video, we will move forward and focus on how we manage a difficult airway. The management of a difficult airway can be described in 2 main parts, which are pre-intubation assessment and intubation based on that assessment. During the pre-intubation phase, an anticipated difficult airway is recognized, which allows the anesthesiologist to prepare thoroughly by planning airway management strategies. Despite careful assessment, difficulty may still arise during the intubation phase, resulting in an unanticipated difficult airway. In such cases, rapid recognition and a structured response are essential. In pre-intubation planning, we assess 5 key areas as recommended by the American Society of Anesthesiologists. The 5 questions we ask are whether laryngoscopy is likely to be difficult, whether ventilation with a face mask or supraglottic device will be challenging, whether the patient carries a significant risk of aspiration, whether they are likely to desaturate rapidly during apnea, and whether performing an emergency invasive airway such as cricothyrotomy would be difficult. Based on these 5 key questions, we plan whether to proceed with induction and intubation or perform awake intubation. Let's look into each of the 5 questions, starting with laryngoscopy. If laryngoscopy is not predicted to be difficult, this usually suggests that intubation is likely to be straightforward and successful, so we may proceed with intubation after induction of general anesthesia. However, if laryngoscopy is expected to be difficult, then intubation may fail despite multiple attempts. In that case, it becomes essential to move on to the remaining questions, which help us determine whether ventilation and oxygenation can still be maintained safely if intubation is unsuccessful. Second, we assess the likelihood of difficult mask ventilation or supraglottic airway placement. These techniques act as safety measures for ventilation and oxygen delivery if intubation fails. If these backup measures are not feasible, the patient should remain awake and able to breathe on their own to avoid hypoxia. If mask ventilation and supraglottic airway use appear feasible, we may proceed with intubation even if laryngoscopy is predicted to be difficult. The reason is that we know oxygenation can still be maintained using these backup techniques if intubation fails. However, before committing to this approach, we still need to consider the remaining questions to ensure overall safety. Third, we assess the risk of aspiration. Patients who are non-fasted, pregnant, or have gastrointestinal obstruction are at higher risk for aspirating gastric contents. After induction, this risk increases because general anesthesia abolishes protective reflexes such as coughing and gagging, which normally guard the airway. If aspiration risk is high, especially when combined with predicted difficult laryngoscopy or ventilation, we should strongly consider awake intubation to preserve airway reflexes. If the risk is minimal and ventilation is expected to be easy, intubation after induction may be appropriate. Fourth, we assess the potential for rapid oxygen desaturation because during the apneic period of intubation, oxygen is no longer delivered to the body. So, patients with limited reserve will desaturate faster, increasing the risk of hypoxia and related complications. In such cases, awake intubation should be considered to reduce the risk during apnea. Finally, we anticipate potential difficulty in accessing invasive airways such as cricothyrotomy and prepare the necessary equipment and strategies to ensure rapid access if standard airway management fails. Only after this assessment should we proceed with intubation following induction of general anesthesia. If invasive airway access is deemed difficult, we must again consider awake intubation. Any single factor, or a combination of factors, may be significant enough to make awake intubation the safer option. Now, there are two possible outcomes with awake intubation, which is usually performed using fiberoptic guidance. Awake intubation can either be successful or it may fail. In the event of failure, we must resort to alternative invasive techniques, such as awake tracheostomy under local anesthesia, which would require the involvement of an ENT surgeon. When the airway is deemed not difficult, we can proceed with intubation after induction of anesthesia. Most guidelines advocate a stepwise approach to airway management, which incorporates all available techniques. These include tracheal intubation, face mask ventilation, supraglottic airway placement, and, in a cannot intubate, cannot oxygenate situation, front of neck access. The 2022 ASA guideline for post-induction difficult airway management begins with an initial attempt at intubation. If this attempt fails, two key principles should guide the next steps. First, call for backup support early. Second, limit the number of intubation attempts, as repeated efforts increase the risk of trauma, edema, and laryngospasm or bronchospasm. To optimize the success of the second attempt at intubation, it is necessary to first ventilate the patient to replenish the oxygen reserve. Ventilation is most often performed with a face mask, with or without the aid of an oral airway. If face mask ventilation fails, a supraglottic airway device should be used to attempt ventilation. From there, depending on whether ventilation and oxygenation are adequate, two different pathways emerge. If oxygenation can be maintained with a face mask or supraglottic airway, we follow the non-emergent pathway, which allows time to reassess, optimize technique, and consider alternative intubation strategies. If, however, ventilation and oxygenation cannot be maintained, the situation becomes emergent, and we must immediately proceed with rescue measures. The emergency pathway is taken when intubation has failed and ventilation with both face mask and supraglottic airway is also unsuccessful, a situation known as cannot intubate, cannot oxygenate. In this critical scenario, help must be called immediately because the patient is no longer being ventilated and oxygen reserves will rapidly deplete. Preparation for invasive airway access should begin without delay, using options such as surgical cricothyrotomy, needle cricothyrotomy, or surgical tracheostomy. While preparations are underway, one may attempt further intubation only if optimization strategies are applied, but it is vital to remain aware of the limited time available. Attempts should be kept to a minimum, and if oxygenation is not restored, the clinician must proceed promptly to emergency invasive airway access to prevent hypoxia and cardiac arrest. To summarize, airway management begins with pre-intubation assessment guided by 5 critical questions. These help us decide whether to proceed with awake intubation or intubation after induction of general anesthesia. Awake intubation is usually performed with a fiberoptic scope, but if it fails, an awake tracheostomy under local anesthesia may be required. If assessment suggests intubation will not be difficult, we proceed after induction. Should the initial attempt fail, our priority is to maintain oxygenation. We start with face mask ventilation. If this is successful, we follow the non-emergency pathway, either awakening the patient or trying alternative intubation techniques to improve success. If face mask ventilation is inadequate, we insert a supraglottic airway. When this provides effective ventilation, we again remain on the non-emergency pathway and may even continue surgery under a supraglottic device if appropriate. However, if both mask and supraglottic ventilation fail, and intubation is also unsuccessful, we face a can't intubate, can't ventilate situation. At this point, we must switch immediately to the emergency pathway and secure the airway through invasive techniques such as cricothyrotomy or tracheostomy. This is the 2015 unanticipated difficult airway management algorithm from the Difficult Airway Society. It follows the same principle as the ASA guideline, providing a clear emergency pathway when intubation is unexpectedly difficult. The algorithm begins with Plan A, where the goal is tracheal intubation. Up to 3 attempts are allowed, with a possible 4th by a more experienced colleague, but each attempt must be optimized. If intubation fails, the process moves to Plan B. Plan B involves insertion of a supraglottic airway device, ideally a second-generation device. If oxygenation is restored, the team should pause to decide whether to wake the patient, continue with surgery using the device, or attempt intubation through it. If oxygenation is not possible, the algorithm advances to Plan C. Plan C is a return to face mask ventilation. If this restores oxygenation, the safest option is to awaken the patient. If oxygenation still cannot be achieved, the situation becomes can't intubate, can't oxygenate, which requires Plan D. Plan D is immediate emergency front-of-neck access, usually by scalpel cricothyroidotomy, to re-establish oxygenation and save the patient's life.